welcome, and we'd like
Yep.
to ask you about our first manuscript, which is article number 7, dual plane treatment with highly concentrated hybrid cooperative complexes of hyaluronans for facial atrophic acne scars. And Dr. Cox, many patients seek our help as dermatologic surgeons for management of atrophic acne scars, and many of us use fillers, but there's really variability in consistency and duration. The filler described here in the study is marketed under the name Profhilo. It's not available in the US. Do you have experience with this filler? And even outside of this filler, do the techniques described in the study, along with findings from the study, mirror what you see in your practice and how you approach patients with acne scarring in your practice?
So I am not familiar with the Profhilo since it is not available in the United States. I would argue with their discussion that this cross-link HA is that our normal cross-link HA is short-lived once it's placed in the dermis, because as you know, both of us inject a whole lot of filler, and with experience, we know that products like Nasha, Vycross technology, they stay around a long time, and they can stay around for years. When I inject around the eyes, I've had patients come back 5, 10 years later, and they still have HA around their eyes. So, they do acknowledge the limitations of the study in that the patients only were followed up for 4 months, so they can't really know the duration of this product. And the study also doesn't really address their hypothesis that the non-cross-link hybrid cooperative complex stimulates more fibroblasts and keratinocytes than our traditional products. They don't really have that information sort of delivered to us. So fillers definitely have been used to treat acne scars for years. I've used them for years. I would say that the consistency and the duration is variable. How this treatment is different from our regular filler is that most fillers use a cross-link form of HA, and that helps to plump up the skin, but the HCC combines with different size HA molecules, and it mimics the way HA naturally exists in the skin, which is important for stimulating collagen production. Rather than filling in the gaps, it prompts the skin to rebuild itself, and the concentration of HCC is also greater than what is normally found in our traditional fillers. The study did look at 3 types of scars: ice pick, rolling, and boxcar scars. And in my practice, different types of scars call for different types of treatment. So this is kind of a drawback of the study, since they only implemented cannula subcision. They didn't implement any energy-based devices. But this is also the strength of the study, since it allows for a pure data analysis. But in the real world, in my practice, multimodality therapy is usually initiated. I do subcision and then filler. For rolling scars, I use cross technology or cross technique with phenol for ice pick scars and using a toothpick. And then I use radiofrequency microneedling or skin pen microneedling with either PRP or PLLA topically. I use Fraxel 1550. I use V-beam for vascular scars, and I use Fraxel 1927 for hyperpigmented scars. So that gives you the whole gamut of kind of how I treat scars.
Excellent. Those are great points. And thank you for your insight.